this lesson, we're going to cover diabetes insipidus, or DI. This is something I've seen quite a few times working in the neuro ICU. You see it in patients with different brain injuries, and you also see it in patients who you're preparing for organ harvest. So now this is a bit of a misnomer. It was originally named diabetes because they noticed polyuria and polydipsia, which are signs of diabetes mellitus, but insipidus actually means undefined. So they weren't really sure exactly what was going on, just that it was similar. But now we know that it has nothing to do with blood sugars at all. Diabetes insipidus is actually caused by decreased action of the ADH hormone, or the antidiuretic hormone. Remember that diurese means urinate, and anti means no. So antidiuretic hormone makes you not pee, or it makes the kidneys retain water. Now in diabetes insipidus, something is causing decreased antidiuretic hormone action. Now either that's hyposecretion by the pituitary gland, which is right here, or it could be just that the body isn't responding to ADH anymore. Either way, we have a lack of ADH action. All right. So instead of retaining water, the patient will begin losing excessive amounts of water in the urine. Okay. This is extreme, guys. They could put out anywhere between 4 to 30 liters of urine in a 24-hour period. That's like 15 large soda bottles. Okay. That leads to excessive dehydration and volume depletion. Usually this is neurogenic, meaning that it's caused somewhere in the brain from a stroke or from a tumor, pituitary tumor. Both of these things could cause swelling and put pressure on the pituitary gland. It could also be caused by infection of or pituitary surgery. All right. There's actually a surgery that we see often in the neuro ICU where they actually go through the nose and remove the pituitary gland. It's called transsphenoidal hypophysectomy. Now, obviously, if we are to remove the pituitary gland, we wouldn't get enough secretion of ADH, okay? So we begin to see excessive diuresis. The kidneys can't hold on to water, and they just dump water like crazy. Patients will put out extreme amounts of urine, and it's usually very, very dilute. It looks nearly like water. So we'll see a urine-specific gravity of less than 1.006. All right, what's urine-specific gravity? When it comes to specific gravity, water equals 1. And urine is normally 1.01 to 1.025. So the lower the number gets, the more dilute and like water it is. With all the water loss, patients are going to become very, very thirsty. This is where it begins to mimic like the signs that we were going to see in diabetes mellitus. Because of the excessive water loss, we see decreased intravascular volume, so the patient gets very hypotensive as well. Now, if you remember back to the hemodynamics lesson, when the blood pressure goes down, the heart rate goes up to try to compensate. So we see the tachycardia going on. Now remember, the kidneys are dumping tons and tons of water. So the blood becomes very concentrated, and the patient's sodium level will get extremely high. This can put the patient at risk for seizures and other neural complications because of severe cellular dehydration. They're going to become lethargic, or they could even progress to comatose. Again, this may also have neurogenic source, so we could see symptoms of that as well. So how are we going to manage these patients? What's the therapeutic management for diabetes insipidus? Well, we want to replace the lost volume, except in this case, we're trying to replace water loss, okay? We've lost a lot of water. So we want them to drink a lot of free water. If they're awake and they can drink, we want to give them free water. That means plain, regular water no tea, no juice, nothing but water, no soda. Now, if they can't take PO, we could insert an NG tube and give them what's called free water flushes. All right. Or we could replace the water in the IV. Now, we can't give straight water in an IV, so we give D5W. That is 5% dextrose in water. Once it's in the body, the dextrose gets used up, and it essentially is like kind of giving water to the patient. We can also replace some of the hormones that they've lost. So one option is called DDAVP or desmopressin. DDAVP, that's probably what you're going to hear a lot of people talk about. This is a synthetic form of ADH and can help improve ADH levels and stop the diuresis. The other is vasopressin, which also mimics ADH and is a potent vasoactive drug. So it's also going to have action on the vessels. So keep that in mind. We usually give this in ICU in the form of a titrated IV infusion, and we're titrating to urine-specific gravity. So whereas the DDAVP can be given just plain PO or through the mouth. We need to monitor the urine output and specific gravity Q hour, every single hour, okay? And report an hourly output above 200 mils an hour. Think about it, that's a ton of urine to the provider. We keep a really close eye on the urine-specific gravity so we can see if the kidneys are able to start concentrating the urine like they should. And of course, we monitor their daily whites. And we need to make sure we do this on the same scale, with the same clothes or linens, and the same time so that we can make sure it's very consistent. Now remember, 1 kilogram of body weight equals 1 liter of water. So you need to keep a really close eye on body weight. So our primary nursing concepts for this patient who's experiencing diabetes insipidus are going to be fluid and electrolytes, hormone regulation, and intracranial regulation. We need to monitor their electrolytes and replace water and hormones. Remember, this is not only likely a neurological issue, but the hypernatremia and the cellular dehydration can cause seizures or neurochanges. So we want to watch this as well. Now make sure you check out the care plans and all the other resources in this lesson to help you really understand and learn what's going on with this kind of patient. So let's recap on our key points. Diabetes insipidus is decreased secretion of ADH from the posterior pituitary gland. It can be caused by some sort of neurological issue or by surgery or removal of the pituitary gland itself. It leads to excessive diuresis and water loss, and we're talking about just huge, large amounts of water loss, which causes very dilute urine, hypernatremia, and cellular dehydration. We want to replace that free water and replace hormones with meds like vasopressin or DDAVP, which is also called desmopressin. And we want to make sure we maintain strict intake and output and measure their urine-specific gravity hourly and make sure that we're monitoring their weights as well. All right, guys, that is diabetes insipidus. It's a really cool disorder. It's really cool to see it when you are working in ICU as you're monitoring these trends on your patient and you know what condition they have. You'll hear people say, oh, they're going into DI. So we know they're going into diabetes insipidus, and we try to get acting on that as quickly as we can to make sure the patient doesn't go into full-blown diabetes insipidus and get these completely out of whack electrolyte levels. So you guys, I want you to use everything you have here to make sure you understand this. Make sure you study SIADH, with these is really the exact opposite of this. But as always, go out and be your best self today. Happy nursing.